Thank you very much. I spend my life looking after patients with breast cancer, and one of the things that has changed, I'm in practice now 14 years and I am going through a midlife crisis at the moment, but one of the things that has really changed is that the disease has changed from being something that has been an illness that frequently led to a patient's demise to now where when you get diagnosed with breast cancer, it's almost like, okay, we're going to now manage a chronic illness and we have to do different things at different stages, but the concept of survivorship has really come in, and one of our biggest challenges is managing survivorship. So I know there are one or two of my patients in the audience, but we now have a large cohort of women who are surviving breast cancer more than 10 years, and it's managing the disease in the context that people will live much longer because we've had many improvements in the disease. And if I could just share a few of these with you anecdotally, there are a number of things such as the drug treatments we give. There are treatments that we have now based on patients' own specific biology, where the drugs literally melt away the tumour. And the biggest challenge for us as surgeons is, if the drugs have melted away the tumour, well, do we need to operate? And one of my ambitions is to make myself redundant so that you don't need breast surgery. But I'll share with you at the end how that strange anomaly that although we're curing breast cancer more and more effective with our drug therapy, because we know an awful lot more about the genes for breast cancer, there are certain individuals who are at greater risk. And when you present a woman with a balanced risk profile saying, actually, because your mother and your grandmother had breast cancer at a very young age and your aunt had breast cancer, we think there's a chance you might have a gene. And if they do turn out to have that gene, then they've got a life decision. Do they consider risk reduction surgery? And that's a really big decision, but one that more and more women are making. So if you look to what the practice was, I trained in Memorial Sloan Kettering Cancer Centre about 15 years ago. I did a fellowship there. And at that time, risk reduction surgery, i.e. removing normal breasts, but who have an increased risk of developing breast cancer, was about 1 or 2% of the work we did. We looked after about 1,200 patients into 1 year, the group of surgeons there. But it was about 1 or 2% of the work was risk reduction surgery, i.e. removing breasts that do not have cancer but have a risk. Now, I have a fellow who came back last year. We still have this very strong connection with Memorial Sloan Kettering, and many of our trainees trained there. So the guy who came back last year, the percentage of risk reduction surgery was what? Anyone want to hazard a guess? It's 25%. So these are people who don't have cancer but are having both breasts removed. And built into that is the reconstructive options. So there are fantastic opportunities with breast reconstruction now. There are newer techniques. The one that most people are familiar with, if you read the women's magazines, where you get the lovely tummy tuck to go with it, and everybody's very happy with that. Even in my own midlife crisis, I'll be happy with that. So these are things that the techniques of surgery have improved. They've revolutionized to give really, really fantastic results. I work with a team of plastic surgeons, and their results are just really spectacular. It's a problem because everybody hears about them, and word of mouth in Ireland is really extraordinary. So they come saying, I want to come to you because I want the plastic surgeon you work with, because they just do a really, really good job. So the improvements in plastic surgery are spectacular. Not only do you do tissue where you remove the tummy and reconstruct a breast, there are now new synthetic, if you like, synthetic tissues where they are used to reconstruct the breast. They're very, very expensive, but they make the surgery very simple, both for the surgeon and the patient. But they get great results. So it's something that things have changed so much, and that the operation can be much shorter because it's technically so much easier to do. So there's a lot changing, and that's what I want to share with you over the course of tonight. I want to go through some of the slides just to give you a flavour of what you do in certain situations. So we want to start with looking at what do we know about breast cancer in Ireland, how frequent it is, what do you do if you find a lump. Then I want to go through the treatments for breast cancer, and then I want to finish with some of the latest advances that are really transforming what we do. So if you can bear with me, the sad news is we still have about 2,400 breast cancers each year in Ireland. The incidence isn't changing, but what is happening is the population is actually increasing. And they worked it out by the time I retire, there's going to be about a 30% increase, but it's nothing to do with increasing breast cancer. It's the age profile of the population. So if you take the corridor from Dublin to Drogheda and try to work out how many people will be living along the M1 corridor, well, basically there will be population living all the way up the M1 from here to Drogheda. Drogheda will be the extension of Dublin suburbs. There will be no green fields, or effectively very few. There will be a huge population in that corridor. It'll be the expansion of Dublin because you can't go south because there's mountains, okay? And that's where the population is going to expand. But the overall population of the country will increase such as about a 30% increase in the number of breast cancers by the year 2030. Each year, the number is fairly static. About 700 die from breast cancer. Now, we think in time that will change because we believe our treatments are getting better. We are diagnosing it earlier. I mean, one of the things that has changed during my clinical practice, I started as a consultant in 1999, and at that time our favourite politicians were delivering the same game. They started with screening. I don't know how they got away with this. They decided they would screen Dublin first, and they it took them 10 years to get down to Cork and Kerry. They managed to get through every election. I don't know how Jackie Healy-Rae never copped onto this, but Cork and Kerry were the last place to be screened because they decided they only had the money in 1999 to start in Dublin, so they put in the investment, and it took them 10 years before they'd say they'd expanded to the south and to the west. So we now have we've had 2 rounds of population screening for breast cancer, which is essentially inviting people in between the age of 50 and 64, and it means you pick up cancer at an earlier stage so the outcome is better. So we're already seeing the reduction in mortality from breast cancer from that very wise decision to invest in 1999 in a screening program. But one of the facts that's important is the lifetime risk for breast cancer is still about 1 in 10. So if you think back to your secondary school class, and let's face it, there was very little co-ed, so if you look around this audience, most of you were probably in single-sex schools, so most of the women here were probably in a class of maybe 20 or 30 women. So 2 to 3 women in that class will get breast cancer, which is a lot when you think back to it. So what are the symptoms that people present with? Well, the commonest one that we see in practice, what do people think is the commonest symptom that, can we, yourself up the back? I hate to engage, I'm sorry for waking you up and asking a question, but what do you think is the commonest symptom that people present with? It's actually not a lump. The commonest is? Pain. 90% of the 7,000 women we see in our breast clinic every year present with pain. And what's the one thing we know is unlikely, not a guarantee, but unlikely to be breast cancer is the presence of pain. It's very rare to have pain. It does happen. But it's clearly a symptom that needs to be evaluated, and people need to be reassured and appropriately investigated. But those who do present with a lump are the ones that we're obviously very concerned about. And if you present with a lump and you're over the age of 40, we're even more concerned. They're the people that we really need to evaluate. Other symptoms that are important are discharge from the nipple, or inversion of the nipple, or changes in the skin. I had met a lady last week, and she said, I never knew that if you had tethering of the skin, that it was a symptom suggestive of breast cancer, and she'd had it for 6 months. So that's unfortunate that our population aren't fully aware of all the symptoms, but changes in the skin is important. And there's also a very important cohort of those who have a very strong family history of breast cancer. So the risk factors, there's a long list here, but the one factor that is most important that you cannot control is your age. The older you get, the more at risk you are of getting breast cancer. And then the other ones are far less important other than those who have a very strong family history. So if your mother had breast cancer under the age of 50 and you have another relative, first degree relative with breast cancer, that means you've got a significantly increased risk because of your family history. So mother under the age of 50 and another first degree relative. With those two things, then you're at increased risk. If your mum was 51, it's okay. She's 55, it's not that significant. But if she was under 50 when she was diagnosed and you have another first degree relative with breast cancer, then it's significant. This is Breast Check, our national breast screening program, started in 1999, finally got to be around the country. And you guess who the politician who brought it in was? Micheál Martin, and he didn't bring it in Cork first. I do not understand that. A man from Cork, usually do it the other way around, but he was a minister at the time and he brought it in Dublin first despite being from Cork. I hope there's no one from Cork here. Is there? Hands up, you could admit it? One? Okay, you're on your own. Okay, so the screening program is 50 to 64 years of age. So every woman in the country who's age 50 to 64, we invite for a mammogram every 2 years. How do we know if you're 50 to 64? They passed legislation back in 1999 to allow them to go through the social welfare payments, to go through the VHI records. Get your data commissioner to look at that. They are allowed to sneak in on any record the government has to work out any female between the age of 50 and 64, and then there's voluntary registration. And it's pretty good. For the last 10 years, over 70%, usually about 75% of women between the age of 50 and 64 turn up and have a mammogram. So that's good. And we know that the data is now showing that picking up breast cancer at an earlier stage is reducing mortality. And that was the aim of the screening program back in 1999, was to reduce deaths from breast cancer. Now, why not? What do you do when you're 65? Well, our country goes, well, we're not doing a mammogram. But we know that it is wise and would be a good investment of taxpayers' money to increase the screening age to 69. And the government signed up to it. In fact, it's in the last Fine Gael manifesto plan for government, increase the screening age to 69. They're saying they're doing it, they're planning to do it. It's just like it took them 10 years to extend out around the country. God knows when it'll happen. But it should happen because it's a good investment of taxpayers' money. It'll reduce people dying from breast cancer. Now, I suppose you've got to work out the water charges and the various other things, but we do have a little bit more money. That's where I would like to see the money being invested. So I met the minister, our new minister, who we really, really like, and he said to me, okay, Arnie, one thing you want to do for cancer, what do you want to do? And I was with someone else in the audience, and they had their vote, and I said, increase the screening age to 69, and he said, okay, and the other person said, we want more doctors, more cancer doctors. He went for more cancer doctors. But we'll get at him. He'll eventually increase it. Now, in the UK, they have gone down to 47. So if you had loads of money, and we didn't have Anglo-Irish Bank, we probably would be 47 to 69, and they're the effective ages. Why do you not screen younger? Because it's not common enough at the age of 40 to justify a national program for it, okay? So it's one of the good parts, though, of our health service. It runs really well, very effective. They paid, they staffed it, and it has really good quality control. Just to tell you a little bit about what it does, Imaging is a mammogram shown on the right there. It's a test that has some discomfort in it. So that makes it challenging to go out and invite people in. And it's varying levels of discomfort depending on who does your mammogram and what time of the month it is. So it is a test. It's not a perfect test, but it's pretty good, the best we have for diagnosing breast cancer. So if you find a lump, what's done? Well, the most important thing for a woman to know is to know what's normal for herself. And if she notices a difference, she should see her GP. The first thing is don't panic. See your GP. And despite we give out, there's lots of really bad parts of our health service. I work in it every day, but I think the breast service is really good. Because if your GP refers you in, you will get seen in one of the 8 cancer centres within 2 weeks if it's deemed clinically urgent. If it's not urgent, it'll be within about 12 weeks. Now, there are some variations on that 12 weeks for the non-urgents because things happen. We have staff who go on maternity leave, who go on annual leave, so it's not perfect all the time. But the vast majority of the time, always, if you have an urgent lump, it'll be seen within 2 weeks. That's not a bad service for one of the 8 cancer centres. There's lots of other parts I could complain about the health service, but I think the breast service does well when you evaluate the whole health system. What happens is the patient, when they're referred urgently, are evaluated, and we use this term triple assessment. I remember during one of the breast cancer scandals that we had many years ago where there was a failure to diagnose, I remember Bertie Ahern using the term triple assessment in the Dáil, and he got it 100% wrong, and nobody knew. But he survived that and many other things. So what is the triple assessment? It's the clinical exam by a breast surgeon, it's the imaging with a mammogram, and it's taking a sample of tissue to analyse it. And they are the 3 components that we do to diagnose a breast cancer. And then it's reviewed by a multidisciplinary team. And this was the benefit of bringing together breast cancer care in a smaller number of centres around the country. Highly politically controversial at the time, very challenging. We went from 26 breast units down to 8. Very, very difficult for staff and people who wanted to have their breast unit nearer, but you don't get the focused expertise of all the components of care if you don't centralise it. And that's been one of the benefits of, we're now over that debate about centralisation. There's no doubt that the quality of delivery of care has enhanced. But triple assessment is what is done for every woman who attends with a symptomatic breast lump. This just to show you some of them. They take the sample of tissue and they use frequently an ultrasound machine to guide the biopsy. They use this as the gold standard. I think it's fair to say it's the gold standard. There is never a 100% guarantee in anything in life. We know the triple assessment is about 98.6% accurate. Nothing in life is 100%. There's the limitations of a mammogram. I said it's a very good test, it's the best we have, but nothing is 100%. So what are the treatments for breast cancer? And this is where things have changed. We've arranged them, and I'll just go through them one by one. First of all, surgery. Sounds like a dreadful thing to do, to have to remove either the lump or the breast. However, there's been a change where previously when I started, I worked with a professor and a mentor who insisted that you remove all the lymph nodes under the arm just to be safe. It was safe, but the side effects for women were very challenging, where there was a very high rate of arm swelling. And the only benefit was if they had disease under the arm. But yet we did that operation for everyone. And I remember my first year as a consultant doing 4 of those operations in one day. You come home exhausted. It's a long operation, technically demanding, but needs to be done if you do have disease underneath the arm. This is breast cancer having spread under the arm. But what we brought in since 1999 was the concept of sentinel node biopsy, where you take out the first node that drains the cancer. And if that's clear of disease, no further surgery. Huge advance for all women with breast cancer, less invasive surgery. It transformed this into a day case procedure, avoiding staying in hospital. When I started, people would stay in hospital for 7 to 10 days with drains under their arm. Now it's day case surgery and home. If there is disease under the arm in the first lymph node, we are even selective as to who actually needs further aggressive surgery. So we have a better understanding of the biology of the disease, and we now have a very selective, personalised approach surgically. So everybody gets a decision made as to what operation to have that's right for them. But remember, when I started back in '99, everybody got the one operation. Take out all the lymph nodes just for safety. So now we have a much more selective, appropriate, targeted plan for each individual woman. In terms of chemotherapy, that is where we've had substantial changes. And the changes are as follows. Again, back in 1999, nearly everybody got chemotherapy. It was hard to avoid it. Really hard. Most people got it, and we were giving chemotherapy to the vast majority of people just in case it was going to help them, because we had nothing else. But I'll show you at the end of this lecture, we're now in a situation where you take the tumor, the individual tumor of that patient, you look at the genetic profile, and you work out a risk score for that woman. And if they have a very, very low score, we know there's no benefit to chemotherapy. If they have a very, very high score, there's clearly a benefit. That technique alone, in the last 2 years in Beaumont Hospital, has reduced the amount of chemotherapy given for breast cancer by what percentage? Can we have a guess? I always pick on the people at the back. Who's right up the back, in orange? What percentage less chemotherapy are we giving in the last 2 years because of this new advance? Want to hazard a guess? It's 70% less chemotherapy. Think about that. All the patients that went through Beaumont Hospital in the last 2 years, if we didn't have this new advance, 70% more would have got chemotherapy, which, what's the biggest problem with chemotherapy? Hair loss. It's not just men are sensitive to hair loss, everybody is. And all the risks of chemotherapy, you know, the biggest problem is traveling into the hospital, trying to get parking. Does anyone know a hospital where it's easy to park? Yeah, but they charge you how much? Yeah. Do you know what the most expensive car parking in any hospital in Ireland is? Anyone name the most expensive car park? Blackrock? No. No. It's Waterford Regional Hospital. Anyone from Waterford? Do you know how much it is to go in and stay there for over 15 minutes? €4. I know, because my mother-in-law was there for a whole week. I couldn't believe it. I wrote to them. I got a nice letter saying back, oh, but we need to make money. Thanks very much. Outrageous. It's the one, Waterford makes Dublin look cheap. Couldn't believe it. So chemotherapy, we're back to, this is a really new test. It makes significant difference, so we're giving chemotherapy to people who need it. Radiotherapy is another component. For those where we just take out the lump, you need to give radiotherapy to the rest of the breast. Hormonal therapy. The tablets have been around, a tablet called tamoxifen. It was actually on the market before I was born. It's been there since the 1960s. But we have had better drugs. We've slightly different ones that work now for women who are after the menopause, but they're very valuable. You know, we say chemotherapy is great. These drugs, hormonal treatment for breast cancer, has made a substantial difference. So we've had where traditionally we gave the drugs for 5 years. Now, we frequently give the drugs for 10 years. Because remember I explained to you at the beginning, our new challenge is to look after people who are surviving 10, 15, 20 years. Previously, it was just given for 5 years. Great, you're alive at 5 years, don't even think about it. Now we've already done a study saying that if you give them for 10 years, it's better. Fantastic. The next issue is, we're currently thinking about a study for what to do for 10-year survivors, people beyond 10. Do you just stop the tablets? Are they some sort of security? Well, they are some, and one of the studies we're thinking about is, we know that if you give the same tablet for 10 years, well, there is a chance that you'll develop resistance to that tablet. So a newer concept is, okay, you take it for 10 years. Now this is a very recently thought up study, designed, will be coming out soon. You're on your tablets for 10 years and you're worried that you'll get resistant to it. So from years 10 to 15, you go on the tablet for a month and off the tablet for a month. Now we've done preliminary studies on that, but the great news is that we actually have a cohort of 10-year survivors to do this study on, which we wouldn't have had many years ago. And that's where we're now into the concept of how do you manage this disease over a 20, 30-year period. Something we previously never had to deal with. And at the bottom is a list of biological therapies. This is where the drug companies and the new drugs that have been discovered are simply fantastic. They have transformed the treatment of breast cancer, and I'll show you that in the next few slides. So just to go through surgery, we've talked about one of the operations to remove the breast. You may just remove the lump. You have to deal with the lymph nodes. Either you take them all out or you take out the first node, and then breast reconstruction. A lot of mnemonics here for different operations. The DEP and the TRAM, that's where you actually take the tummy and bring it up and reconstruct the breast. The other one is where you take the muscle from the back and you bring it around to reconstruct the breast. Not good if you're a professional tennis player, otherwise very, very good. The difficulty is how long these operations take. So if I'm doing the cancer part of it, it may take about 2 hours to do the operation, an hour and a half to 2 hours, okay? But then the plastic surgeon comes in and the DEP averages 6 hours on top of what I do. So that's 2 hours from me, 6 hours from the plastic surgeon, that's 8 hours. Then we've had patients who've had bilateral breast cancer. That's 11 hours. 11 hours of an operation, that's a lot for anybody physiologically. It's also a lot for the surgeon, by the way, 11 hours of work. So it's an operation that is very challenging in bilateral breast cancer. But there are other techniques that are probably more favorable, that are shorter operations, and that's where I was talking about use new synthetic material that you can reconstruct the breast with, which makes it much more straightforward, easier for the patient, and easier for the surgeon. And in fact, having worked with my plastic surgical colleagues, they get great results. And the differences actually are when you reconstruct with an implant, it feels like an implant. When you take the muscle from the back, it feels a little bit like an implant and a little bit like muscle. And when you take the part from the tummy, it feels more naturally like a breast. So they all look good, it's how they feel. And of course, both are very, very important in terms of getting the perfect reconstruction. So the surgery has come a long way, much more sophisticated. The reconstruction doing this tummy, they call it a tummy tuck, but in fact, you're using a microscope with an absolutely minute thread. The needles you would not see with the naked eye. You need a microscope. You're sewing together vessels that you probably would just about see with the naked eye. And you have to ensure that the blood flow goes in from the arterial side and comes out of the venous side. Really spectacular surgery to see being done. This is just to show you the tummy tuck. This is just to show you an example of the sentinel node. So the sentinel node, to help us find that node, we actually use a blue dye where we inject it underneath the breast, nipple, and it goes to the first node, and we can see it visually being blue, which is very straightforward, makes my life very colourful. One downside is, and we always have to warn the poor unfortunate husbands that come and pick them up at 6 o'clock in the day ward to say, your wife will look like a smurf at 6 o'clock in the evening. But please be reassured, she will be back to looking her same self at 8 o'clock that evening, okay? And then the other thing that I've learned to tell everybody, because there's nothing like it when they're going home and you get this phone call at 9 o'clock at night, doctor, my urine's gone a funny colour. It's just a dye flowing out through them. But it's the poor husbands coming along at 6 o'clock going, what did you do to my wife? If you don't tell them that they will look, it's just a temporary thing. They don't look very well when they're blue. It's not our best colour, but it's gone at 8 o'clock. But it helps us find the node that might have cancer. That's how pretty it looks. They're the things that excite us. We like nice coloured things like that. Now, what I want to finish with is just to go through the advances in biology. And if you can look at this slide, I won't make it any more complex than this, but this is a breast cancer cell. And there's a receptor over there called ER. And do you remember the tablets that were developed since before I was born called tamoxifen, the ones since the 60s? Well, they work on that receptor, okay? And we've been giving them since the 1960s, and it's great. We give it for 5 years, 10 years, and now we're looking at giving it 10 to 15 years, and it works very well. Probably the most effective anti-cancer treatment around the world. 200,000 women in the world take this tablet each year, tamoxifen. So it's really, really common. Because it's so common, of course, tamoxifen is very cheap, and the drug companies don't make any money, and they're not interested in it at all. It's cheap. That's the way drug companies work. But there's another receptor on the breast cancer cell that's only present on 20% of breast cancers. And when I started in practice, if you had that receptor, it would mean you would die early. Bad news. HER2 was a bad receptor. You were going to die earlier. And then Dennis Slayman from California discovered in his lab a drug called Herceptin. And what Herceptin does is it binds to that receptor. We still don't understand what actually happens. It binds that receptor but causes the cell to disintegrate. We don't know why, but it does. And I remember being involved in the very first trials where you took all the patients who were HER2 positive and you had to randomize them and say, half of you will get the drug and half of you won't. And I remember seeing the trials going on. You would know who hadn't got the drug because their tumor was getting bigger. And those who got the drug, it was shrinking, evaporating in front of us. So here's a fascinating story. We had this fantastic drug, and the stock price of Genentech was booming. Okay? And what do the other companies do? They take the same drug, break a molecule off. It's like making another bar of chocolate between Cadbury's and Rowntree or whatever. They break a molecule off, they realize it still works on breast cancer, and they market it as the next best thing, or the best thing, for breast cancer. So Genentech made this. They were making a fortune. And GlaxoSmithKline went along, broke a molecule off it very discreetly and said, we've got a new drug for breast cancer, it's brilliant. And they gave it. And 5 years down the line, we're doing the same studies saying, God, this next drug is brilliant. Things are great for breast cancer. We have 2 really good drugs. And then about 5 years ago, imagine this challenge. The doctors went to the head of GlaxoSmithKline and the head of Genentech and said, guys, will you stop fighting with each other saying my drug is better than yours? Would you do the following study? Now, these companies hate each other. They compete for the same cohort of breast cancer. We persuaded them to say, do the study where you give women both drugs. And you might say, that's a no-brainer. Of course you would. Well, it took a long time to persuade them. And guess what happened? When you give both drugs, because the Genentech one works here, and the GlaxoSmithKline works on that part, you get a much better effect. And we now have information. This, I think, is the most exciting thing. We now have information, if you give both drugs, 50% of women, the tumor goes completely cured. So, what's next? There's a third drug out there. And I think the future will be telling the companies, maybe give 3 drugs. For how long, we don't know. Okay? So what do you do when you've completely removed the tumor? Does it come back? Should you stay on it? We're not sure. These are questions that need to be asked. But we have, remember, it's only for a small cohort. 20% of all breast cancers, we have these magical drugs that we think can make a real difference. So if you line up 100 women with breast cancer, 20% will have this receptor, and in 10 of them, we know that the drugs will obliterate the tumor. Our problem now is we can't tell which are the 50% where the tumor is completely gone. Because if there's a little bit left, it'll just grow again. So that's a challenge. We're still doing surgery to try and learn who are the ones who had a complete response, and we're trying to predict that. So there are some of the current challenges. Good problems to have, because women are going to do better based on these drugs. So there's a lot of exciting things happening. It's a whole industry around this. That's just to share with you about the tablets that are around since the 1960s. There's a whole load of them. They work on the estrogen receptor. These are the drugs I was telling you about. This is the Herceptin, and this is the other one from GlaxoSmithKline. By the way, I'll tell you an interesting story. So a couple of years ago, I was giving a lecture to the medical students about this, and I said, you know, I think this is going to do really well. It's working really well, and I made a throwaway comment. I said, God, you know, if I had any money, I'd invest that in the stock market. And I met one of our graduates last year. He said, you know something? I went back to my notes. I looked at the stock price of that company. I looked at now. If we'd listened to you, we wouldn't be working. They would have made a fortune. I said, why didn't I? I wouldn't be here tonight. I'd be lying on a beach in the Bahamas. It's like, but I didn't. And of course, next question, everyone says, what's the third drug? What's the next one? Well, they won't be as successful as that, but they will do quite well. So these are the latest treatments, and what I wanted to just tell you about was one last thing. Oncotype DX is the name of that genetic test where you take a woman's tumor, you analyze the genetic profile, and work out what's the risk. And this is the test that has transformed and made 70% of women in the last 2 years in Beaumont get less chemotherapy. 70% of women avoided chemotherapy based on this test. Do you know how much the test costs? $3,600. And the company, they're an American company, they said, Ireland's too small, we're not interested. You've only 4 million people. We want to get the German market, so we're just going to fly straight to London. And we persuaded them, come to us, we'll work with you. We did the study, we've proved it. Guess what they're doing now? They're over with Angela Merkel saying, look what happened in Ireland. Fantastic test. It might cost $3,600, but chemo costs about $6,000 or $7,000. You're saving money. And they've actually persuaded Angela Merkel based on our data. Kills me. And now they're going to move it into the German market. And of course, like everything in life, it's competitive. Mammoprint is the European version. A gang in the Netherlands, it's a different genetic test. They're trying to make money out of Mammoprint. Oncotype are ahead of the game. It's kind of like IBM and Apple and the way these companies work. But they're all benefiting women in that they're giving us more information about the breast cancer. But it's very exciting. There's going to be more and more of this, and keeping up with it is really exciting because it's making a difference to the patients we treat. Just want to say, to finish with a few slides saying, all aspects of care have changed. Radiotherapy has become more sophisticated. This is a list of you wanted to know the ones for the stock market where you want to book in? Take the names. Not that one actually, not bad. This one didn't make much money actually for breast cancer. They thought it was, if I was given the lecture 5 years ago, you would have run home and invested in that and lost your money. But pertuzumab, maybe. So there's a whole list of them. And, I'm only giving you a fraction. There are hundreds out there that they are trying. Now, it's not cheap. The first one, Herceptin, $2,000 a month. And they decide for people who have bad breast cancer, they'll give it for life. For life, every week, $2,000. Yes, that's where your health budget is going. The competing one, about the same. And these are the other ones that you may choose to invest in the stock market. A whole range of them, all very expensive. But what's the cost of survival? There was, and this will be my last anecdote, in melanoma, we had no drugs for years. And then about a year ago, this really expensive one called IPI. IPI is colloquially known in the medical community as the Joe Duffy drug, because that was the one where, it's $90,000 a year. And there's about 10% where it'll make you live for over a year, and the option would be death otherwise. Anyway, as usual, Joe Duffy got the one patient who required the drug, very emotive, everyone ringing in, and the Minister for Health turns around and goes, we'll pay for it. So it's known as the Joe Duffy drug. That's the way some of the assessments work. But it's a big challenge in healthcare, working out the costs of really expensive drugs where we know there's a benefit, but there's a price on all benefits. Should you be building more, sorting out our A&E departments, or should you be spending the money on this? They're the difficult challenges for any Minister for Health. Thank you very much. Well, I think the take-home message is that the treatment of breast cancer has changed substantially over the last decade. In surgery, we have less invasive approaches. We now have more specific drug treatments. So we're giving less chemotherapy, but much more specific chemotherapy targeted to the individual patient. So overall, we're now in the era of personalised treatment for breast cancer, based on the biology of the disease, where we know an awful lot more and have much more significant drugs to help in the fight against breast cancer.
Well, it was very interesting tonight, and certainly the advances in the treatment recently is just amazing. This is my first time at the lecture, so I would definitely recommend it to family and future and friends.